So I'm a specialist nurse, an osteoporosis specialist nurse. I work with the Royal Osteoporosis Society, and I work there across a number of projects as a clinical advisor. So let's start with a few facts about osteoporosis. It's a medical condition when bones lose strength and they break more easily. And it's these broken bones or fractures, as I say, they're called fragility fractures in the medical world, that cause the pain and the disability associated with osteoporosis. And then we have these spinal fractures, not broken bones in the way we think of broken bones, sort of squashed, compressed bones in the back that can cause pain, but also in the long term can cause height loss and curvature of the spine. Important to say that there is a diagnosis of osteoporosis made from something called a bone density scan. So if your bone density is lower, quite a bit lower than the average adult, this is a really important risk factor for fracture. It tells us that your bones are likely to be less strong. And if your bone density is at a certain level, then you are diagnosed with osteoporosis. It's got a very specific meaning there. But I think also just an important fact to just stress is that you only get the pain, the loss of height, the curvature and the symptoms if you've got broken bones. So having low bone density doesn't give you any symptoms at all. And I think sometimes that's not quite understood. Let's just talk a little bit about what I'm describing as the living skeleton. So it's really important to understand that your skeleton isn't a sort of dead, inert thing sitting inside. It's constantly changing. If you were able to look inside your bone, you'd see these struts, this scaffolding, particularly in the ends of your bones and in your spine. And then on the outside of the bone, there's a kind of a shell, a hard shell. And this is constantly changing. There are special little cells wearing away at nibbling away at these struts and taking out little chunks of bone and then refilling them. And that's a normal, healthy thing that keeps your skeleton, your bone tissue strong. Now, with osteoporosis, this seems to get out of balance, and more bone is being worn away than is being rebuilt. And then as a result, we get the thinning of those struts inside the bone and a thinning of that cortical shell. So that in itself is starting to affect the strength of the bone. But the really important thing that can happen is that the whole structure inside the bone can break down, and that's when bones become really much weaker. These at the bottom are examples of the typical kind of fractures, broken bones that you get with osteoporosis. So these broken bones can happen anywhere apart from the skull and the fingers and toes. We don't think those are related, but there are common sites. So we see fractures quite often in the wrist, in the back, as I've described, the squashing down of the spinal bones, but we also see fractures in the hip. And when we talk about a hip fracture, a broken hip, we actually mean what's the top bit, the neck of your thigh bone, and that's vulnerable too. So these are common sites. So really important to understand that osteoporosis, meaning bones have lost strength and are more likely, have a tendency to break more easily. We know that it affects a lot of people. These broken bones affect 1 in 2 women and 1 in 5 men in older age. So it is a common problem. What causes osteoporosis? Well, the biggest thing is old age, actually, that imbalance in the bone building and the bone wearing away. That it all seems to happen, and things get a bit out of balance when we're older, unfortunately. There's a genetic input, so 80% of our bone strength is probably down to our genes, but there's 20% of we can do something about, so lifestyle is important. There's something around gender, because women start off with smaller bones. They lose bone more rapidly around the time of the menopause when their estrogen levels drop, and they do live longer. So as the process goes on, they're more likely to end up with fractures. A very important risk factor for future fracture is having had one already. So that's why it's very important, if you do break a bone easily, to go and get your bones assessed and think about a treatment for your bones, because one fracture does lead to another. It's a very good sign, if you break a bone easily, that your bones aren't as strong as they should be. There are these risk factors you can change. So if you're very low in body weight, and some conditions like anorexia nervosa are associated with osteoporosis. We know immobility. So if you're not using your bones, then they get weaker. Smoking, alcohol, And actually, people who unfortunately are falling over quite a bit are obviously at risk. These are things that relate very much to rheumatoid arthritis. So there may be immobility problems if you've got a severe condition, and you may very well be on a medication such as a steroid that we know, unfortunately, is not good for bones and can make bones weaker. And the other thing that's really important to understand is that there's something about inflammatory conditions like rheumatoid arthritis that actually seems to affect bone strength. So how do you know if your bones have lost strength? Well, we don't have a perfect test, I would say that. So although many of you will have heard of bone density scanning, which is very useful, particularly when we're trying to decide if you need to take a bone strengthening drug. And we do know that if you go and have a bone density scan, the lower your bone density, the greater your risk of breaking a bone. And as I said, osteoporosis is diagnosed on a scan if, in fact, your bone density is lower than the average adult. But it is important to say that bone density is only one part of bone strength. So it's the bit we can measure, but it's not a perfect measure. We do something in the medical field called fracture risk assessment. So what that means, you go along and they look at all your risk factors, all the things that research has shown may be affecting your bone strength, and they piece all those together and they build up a picture of your fracture risk in the next 10 years. So this is how they kind of work out what your bone strength is likely to be like in order to decide if you need a drug treatment. And just to say also that in terms of tests and scans and investigations, it's x-rays that still are the best way of looking to see if you've actually had a fracture. Now, we've got a range of drug treatments for osteoporosis. I won't go into them in a lot of detail. We've got drugs called bisphosphonates, alendronate, zoledronate are examples of those, but we've got other treatments too: denosumab, teriparatide, strontium anilate, HRT, and romosozumab. And who gets them? Well, they will give it to you, as I say, if you've got a high fracture risk. It's usually in the people who are over 50, because we know, as I say, that bone in itself just tends to get a lot less strong. The structure breaks down as we get older. They sometimes give treatments to younger people who've got very strong risk factors. So if they're on a high steroid dose, they're breaking bones perhaps, or they've got, they're continuing to lose bone density, they may give you an osteoporosis drug, but not so often. And what are the steps before you need a medication? Well, when people say, do I really need a bone density scan? Not always, because I think if you're older and you've got this high fracture risk because you're on a steroid dose that you're going to stay on for quite a long time, you're over 70 perhaps, you're on a higher dose, and particularly if you're starting to break bones, then they may treat you without doing lots of bone density scanning and so on. I thought I'd just make that point. Otherwise, when you get to around the age of 50, that's the time, particularly after the menopause for women, when they do a kind of overall bone assessment almost routinely if you've got rheumatoid arthritis, I would think, and then they would look at often your bone density as part of that. As I say, if you're younger, you would need to be referred to a specialist, and occasionally they would use a treatment if you're on the high dose steroids, but they are quite cautious about using long-term medications, particularly in younger people. Let's move on to what you can do yourself. So there's some positive messages here, which I hope you feel you can take away something you can do. So healthy, balanced eating, a calcium-rich diet with adequate protein, that's a really good starting point. If you can be doing exercise, then using your bones is great. And there are specific types of exercise that are best, what we call weight bearing, so standing with a bit of impact behind that. And also working on particularly on your muscles, muscle resistance exercise. Those are the best things. Keeping an appropriate body weight, so not getting underweight, not smoking, not having excessive amounts of alcohol, and getting enough vitamin D. So that vitamin D helps you to absorb calcium, and we get that from sunlight during the summer, but probably need to consider a supplement during the winter. And the other thing as we get much older is to think about balance and muscle strength exercise to prevent falls. So it's not only about exercise for bone strength, it's about exercise to reduce your risk of falling as you're older. So if you are getting on top of that inflammation, everything's managed, then that's going to be the best thing for your bones. So discussions with your healthcare professional. There are now many other options beyond steroids, so other treatments, which is great news. And I understand that some of the newer biologic treatments are actually being used for more moderate rheumatoid arthritis. So there really is the opportunity to perhaps not be on steroids in the way people were in the past. So healthy lifestyle, having bone checks and scans if you need them, and then thinking about this wider fracture risk assessment as you move into postmenopause as a woman, or you're over 50 as a man. Occasionally drugs might be necessary for younger people, particularly if there's continual rapid bone loss. When we really focus on the bone density meaning, that's where the osteopenia bit comes up. So if your bone density is significantly lower than the average adult, they call it osteoporosis. If it's a bit less, not a bit lower than average, but not in the osteoporosis range, they call it osteopenia. So they're sort of terms about bone density. They're not a condition as such in themselves. I think it's important to understand that. All the treatments are generally safe long term, as a broad comment, and they are given it's about balancing up risk and benefit a bit. There are a couple of kind of rare adverse effects, one of which is a sort of poorly healed area in the mouth when you have a tooth out, but it's very rare. We're talking about between 1 in 1,000, 1 in 10,000, and that usually the benefit you're going to get from the drug is going to be an awful, in terms of reducing your fracture risk, is going to be a whole lot less than this rare side effect. So you need to look at those. They will always be balancing these things up, but generally if you need it, then it's safe to carry on. We've got effectiveness research that goes on now up to 10 years with denosumab. It will depend on the individual situation, because I think, as I said in my slide, if you've got very strong risk factors, so if you're going to be on regular steroids, or you've broken bones and you clearly got weaker bones, then they may not need to regularly scan you, because it's not going to change the decision about treatment. Remember that this scanning is used mainly to help target treatment and decide who needs it. But if they clearly know you need a treatment, they don't need a scan. So I think people feel naturally they would like to have regular scans because they kind of want to know what's going on. But if it's not going to change the answer, and I wouldn't be saying that so much when I'm talking about some risk factors, but things like rheumatoid arthritis, steroid use, they are very strong risk factors, and particularly if you've broken bones. So don't be too surprised if they just say, look, at your age, you're now older, you've had the fractures, I just want you to stay on the treatment. But for many people, if they are using scanning, it would be probably every 3 to 5 years. It's certainly not worth having them every year or 2 years. There's not enough significant change to make a difference. A really interesting and very current question. If you go on any of the the sort of community chat rooms, there's a lot of discussion about REMS, so we get a lot of questions. It's a type of scan. It uses radio waves, it uses ultrasound, so it uses sound waves, and it is measuring what's going on in bones. So it certainly is really promising and interesting. There seems to be accuracy there, but I think it's still in the research field, would be my conclusion on that. And we don't know if it's reliable. We don't quite know yet. You need a lot of work on these kind of technologies to see if they're really sure. We don't exactly know what level indicates that you're at a higher risk of fracture, of broken bones. We would never recommend being overweight, but there are some people who are underweight, and therefore not only is there not the same pull on the skeleton, but you haven't got any padding if you fall, to be honest. And interestingly, we produce a sort of estrogen in our fatty layer post-menopause. So not advocating being overweight, I'm just saying be a little bit aware that you may be a bit
healthy weight,
underweight. Yeah. There are different ways that exercise can help. It can help to promote bone strength. So that's where, and not everyone can be doing impact exercise. Not everyone can be jogging and doing that kind of work. But if you can, that has a particular benefit. Alongside that, yes, absolutely, building on muscles and working them quite hard. So if you're lucky enough to be able to do that, and I very much appreciate not everyone can, but that would be the optimum, is both of those two. But yes, absolutely, work on balance, work on back muscle strength, because that supports your spine. So if you get a fracture or you're moving and lifting, if you've got good support to your spine, then that's going to help as well. So yeah, lots of ways exercise can help. And again, we've got videos and we've got fact sheets on our website that look very much at exercise for bone. But I would say anything's better than nothing. So please don't feel, if you're someone who is quite limited, you know, even if it's standing up every hour and when you're watching the television, and even that's better than being immobile. Tai Chi very useful for balance, and Pilates and yoga can be very useful for, beyond all the kind of well-being and so on, can be very useful for muscle strength and keeping you fit. And probably need to add some other things in if you can, but they're, you know, they've got a really important part to play. It really doesn't matter how you get your calcium. We tend to talk about dairy just because it's a big part of the Western diet and it's easy and it's inexpensive and so on, but it's not absolutely essential. So you just need to take extra care. So, and it's really more people transitioning over to a new diet. If you're going to eliminate any food, you need to replace it. So you need to have dark green leaf vegetables. You need to perhaps have something like tofu or something which is synthesized with calcium. So, and if you can't get that, then calcium supplements. We'd say go for diet first because you get all the nutrients you need. But if you can't do that, there are calcium supplements you can choose. Just finally, a quick mention of all the information that we have back at the Royal Osteoporosis Society. So lots of information on the condition, risk factors, scans and tests, bone health, drug treatments for bones, as well as living well with fractures, which I haven't covered, but I do know some people are really needing help with pain and symptom management. So lots there if you need it. We have a specialist helpline. We have support groups. We have a membership and regular email support for those who need it. So come to us if you need specific osteoporosis help.